Hello and welcome to Anaesthesia Skills Simplified with Dr. Rishabh Gautam. Let's make anesthesia safer, simpler, and smart.
Do you know the most common cause of anesthesia related deaths is pulmonary aspiration? What is pulmonary aspiration? Pulmonary aspiration is the entry of gastric or esophageal contents into the lower respiratory tract. It may happen at the time of induction, at the time of maintenance, or at the recovery. It occurs due to the loss of protective airway reflexes. And to overcome this problem of pulmonary aspiration, a protocol was devised which was named as Rapid Sequence Induction and Intubation. In the short form, we call it RSI. So, what is RSI? RSI is the rapid control of airway to minimize the risk of pulmonary aspiration by minimizing the time between the loss of consciousness and intubation. So let's come to the indications of RSI. The indications of RSI are very clear. RSI is indicated in all those patients who are at high risk of pulmonary aspiration. The patients who are at high risk of pulmonary aspiration are usually the patients with full stomach, the patients whose fasting status is not reliable, in cases of acute trauma or acute pain, in patients with chronic illnesses where the gastric emptying time is increased, like in diabetes, chronic kidney diseases, in patients with gastric outlet obstruction, bowel obstruction, if a patient is having a history of bariatric surgery, the hiatus hernia, esophageal cancers, and also in the patients who are critically ill and needs the rapid airway management, patients with pregnancy patients whose pregnancy status is more than 20 weeks. In all these patients, the risk of pulmonary aspiration is very high. So in all these patients, the RSI is indicated. Contraindications of RSI are anticipated difficult airway, severe hypoxia, and pediatric patients. So let's come to the core concept of RSI. The core concept is very simple. Its name suggests it's rapid, it's sequential, it follows a protocol. And protocol to prevent the pulmonary aspiration. And to understand this thing, you have to understand the 7 P's of RSI. The 7 P's of RSI are: number 1 is preparation, number 2 is pre-oxygenation, number 3 is pre-medication, number 4 is paralysis and induction, number 5, and a very important one, is cricoid pressure, number 6 is placement of tube, and number 7 is post-intubation management. So let's go one by one and understand the core concept of RSI. First of all, preparation. So you have to prepare all these drugs, draw and label all the drugs, attach all the monitors, prepare your difficult airway cart, and prepare your suction machines. You should have a suction machine in hand and it should be on before inducing the patient. The suction machine should be fully functional. So check your suction machine, which is most important. And as per protocol, keep 2 suction machines ready before induction in RSI. So prepare all the machines, prepare your equipments, prepare your difficult airway card, prepare your suction, switch on your suction machine and put the suction catheter near to the head end of the patient before induction. Label all the drugs, prepare your vasopressors ready. Prepare all emergency equipments ready. Keep your plan B always ready in your mind in case of difficult airway. Keep your difficult airway card ready. So when you are prepared for the RSI, let's go for the second P of the RSI, which is pre-oxygenation. So pre-oxygenation should be done with 100% oxygen for 3 to 5 minutes. So it helps in reducing the nitrogen from the lungs. It causes a nitrogen washout and increases the safe apnea time. Third is pre-medication. Depends on the patients and the status of the patient and the anesthetist. So pre-medication, you can use the anticellulogs if it is indicated with your the choice of your induction agents. You can use glycopyrrolate, and you can use fentanyl or lignocaine. Fentanyl you can use to blunt the hemodynamic response. RSI is a rapid process. Whatever you are going to do, everything needs to be rapid. Let's come to the fourth P, which is paralysis and induction. So to induce the patient during RSI, you can use various induction agents. The classical induction agent of choice is thiopentone. The dose is 3 to 5 milligram per kilogram IV. The other inducing agents which can be used include propofol. It is a very fast acting drug, but it can lead to the hypotension or shock. So you have to be careful while using propofol in the patients of shock. The dose is 1 to 2 milligram per kilogram IV. Another agent you can use is etomidate, which is the dose is 0.2 to 0.3 milligram per kilogram IV. This drug is hemodynamically stable and can be used in patients with shock. But the problem with this drug is single dose of etomidate may lead to adrenal insufficiency. So you have to be cautious while using in patients with adrenal insufficiency or in cases of sepsis. Other agent which can be also be used is ketamine. The dose of ketamine is 1 to 2 milligram per kilogram IV. This is a good drug to be used in cases of shock and asthma patients. So remember, choose your inducing agent on the basis of physiology of the patient and not on the basis of the habit. The drug of choice for muscle relaxant is succinylcholine. The dose is 1 to 1.5 milligram per kilogram IV. The other drug which can also be used in place of succinylcholine is rocuronium. The dose is 1 to 1.2 milligram per kilogram IV. But remember one thing, succinylcholine is the drug of choice for muscle action, and rocuronium should only be used in cases where succinylcholine is contraindicated. The contraindications of succinylcholine are hyperkalemia, severe crash injury, or a severe burn patient of more than 24 hours. If you are using rocuronium in case of succinylcholine, then keep Sugamadex ready. Remember, use the drugs on the basis of physiology and not on the basis of habit. Now let's come to the next P, which is cricoid pressure. It is a very important point. Cricoid pressure is very important in RSI. Cricoid pressure is the backward pressure given at the level of cricoid cartilage against the cervical vertebra. It helps in reducing the passive regurgitation. Remember the timing and the pressure. The cricoid pressure should be started before the induction agent is being given, yani before loss of consciousness. We should put our hands, identify the cricoid cartilage and put our hands, the thumb and the middle finger over the cricoid cartilage. Before the patient loses his consciousness, that means in the awake situation, give only 10 newtons pressure. And as soon as patient loses his consciousness, the pressure needs to be increased to 30 newtons. And you should maintain this pressure until the tube is placed and confirmed with cuff inflation. You have to release the cricoid pressure only after the cuff inflation, not before that. In cases of difficult laryngoscopy, immediately release the pressure, because remember, during RSI, greater risk is not the pulmonary aspiration, but the greater risk is not able to intubate. So remember this thing, the greater risk is not able to intubate. So if in cases of difficult laryngoscopy, remove the cricoid pressure immediately. We will learn more about the cricoid pressure in the next video. So now come to the next P, which is placement of the tube. Placement of the tube is confirmed with the EtCO2 monitor or auscultation, or with the chest rise. And in post-intubation management, you should check first of all confirm the placement of the tube, then inflate the cuff, and then release the cricoid pressure, and then secure your tube and connect the patient to the ventilator for further management. So what are the complications of RSI? The complications of RSI include failed intubation, hypoxia, hypotension, bradycardia, and the risk of aspiration. There is a very common term called modified RSI. What is this? The modifications are being done in the classic RSI approach to improve the outcome of RSI, and these modified protocol is called modified RSI. The modified RSI balances the risk between the aspiration and hypoxia. In classic RSI, all the doses were given are the premeditated and pre-calculated doses, but in modified RSI, the inducing agent is being given on the basis of as a titrated dose. In modified RSI, you can use either succinylcholine or rocuronium as the drug of choice for muscle relaxant, but in classic RSI, succinylcholine was a drug of choice. No other option was being preferred over succinylcholine. But remember, succinylcholine is the preferred choice in modified RSI also, and the succinylcholine should only be replaced if there is any contraindication, and can be replaced with rocuronium. Another modification was the cricoid pressure. The cricoid pressure, according to modified RSI, is an optional thing, because if you go with the cricoid pressure, so sometimes you may feel difficult laryngoscopy and the greater risk is not able to intubate. So in modified RSI, the cricoid pressure became optional. Whenever you feel that you are facing difficult laryngoscopy, immediately release the cricoid pressure. But in classic RSI, cricoid pressure is never released before intubation. Another change in modified RSI is about the bag mask ventilation. In classic RSI, there is no scope of bag mask ventilation. There is no bag mask ventilation in classic RSI. But in case of modified RSI, if you feel the patient is having hypoxia or saturation patient is desaturating, then you can use bag mask ventilation with gentle and low pressure. As we discussed in the starting of the video, the RSI is a sequential process. So let's learn what is the flow of RSI. In the flow of RSI, first of all, you have to identify the risk. When you have identified that this patient could land up in the pulmonary aspiration, and we are going to use our rapid sequence induction and intubation technique for this patient, then first prepare your OT, prepare your patient. Preparation is equals to safety. So prepare everything, prepare OT, prepare your airway card, prepare drugs, and prepare patient. Second, pre-oxygenation. Pre-oxygenate the patient. After pre-oxygenation, pre-medicate, and after pre-medication, give induction agent as per the physiology of the patient. And as soon as you give the induction agent, immediately give muscle relaxant and start with cricoid pressure. Start cricoid pressure before giving the induction agent, and as soon as patient loses its consciousness, increase the pressure of to 30 newtons and maintain this cricoid pressure until the tube is placed and cuff is secured. So when you feel that the patient is completely relaxed, then immediately go for intubation. There is no scope of back mask ventilation unless patient is desaturating. And when you have placed your tube, immediately confirm whether the tube is in place. If tube is in place, then inflate your cuff, and after inflating the cuff, release the cricoid pressure, secure the tube and attach the patient to the ventilator. So this is how we learned about RSI, rapid sequence intubation, in this video. If you like my video, then please like and subscribe this video. Thank you.